My name is Robert Steele. I'm a professor here in the Department of Philosophy at UNO and also a member of the Medical Humanities faculty. It is with pleasure that I can welcome you to the third event in our new Ethics of Medicine lecture series here at UNO. Every last Thursday of the month at 7 p.m. Central, yours truly is moderating an hour-long Zoom event featuring a scholar in medical ethics applying their cutting-edge research to pressing contemporary problems. Now, putting together a series is a bit of an undertaking. When it comes to this one, there are lots of people to thank, but I'd like to specifically thank the Ted Kooser Health Humanities Center for their financial support for the series, as well as Courtney Kopitz of the College of Arts and Sciences for her invaluable work in building our web presence, advertising, getting Zoom figured out, really just getting the event to actually run. For this talk in particular, we're very excited and honored that Dr. Ben Schwan will be here presenting to us. Dr. Schwan is an instructor in the Department of Bioethics at Case Western Reserve University and a clinical ethics consultant for the MetroHealth System in Cleveland, Ohio. Previously, he received his Ph.D. in philosophy from the University of Wisconsin-Madison and spent 2 years as postdoctoral fellow in the Department of Bioethics at the National Institutes of Health Clinical Center. Now, there are a lot of really great things about Dr. Schwan, far too many to list, but one I'll highlight is that he is a rare gem in our field insofar as he combines astute ethical judgment with significant technical competence. And it is for that reason I'm especially pleased to see that he has turned his recent attention to a topic of no small technical complexity, and hopefully soon he will solve it for all of us. The topic is measures of fairness in health rationing, which is what he is presenting on for us here today. For this event, the chat function is disabled, but we are taking questions through the Q&A function. So you can put those questions in whenever, as they occur to you. Once the presentation's over, we will break for a Q&A session. I'll probably kick things off with a couple questions of my own. It's the privilege of moderating. But after that, I'll move on to questions from the queue. So we really do encourage you to pipe up and share your thoughts in the Q&A. Please do that. I think with all that being said, I'm not going to take up any more of your time, and instead I will turn things over to Dr. Schwan.
Great. Well, thank you very much for the introduction and for having me. I'm really excited to talk with you all about this topic. Let me share my screen. There we go. Okay, yeah, today I'm going to be asking you to think about how fairness considerations bear on the question of how to allocate scarce medical resources. And I guess it's worth noting right here at the outset that this is a work in progress. The pandemic and what's gone on in the last year has helped reveal, I think, some longstanding ethical issues that exist within our healthcare system. And this fairness problem that I'm going to be discussing today is one of them. Cards on the table, I'm not sure whether, or if so, how the problem I'm going to be discussing should be solved. But my hope is that I can help us make progress in answering the questions I'm going to be asking today. So my goals are, one, to show that what I'll call the dominant model of scarce healthcare resource allocation has a fairness problem. That's goal number one. And goal number two is to provide some tools for thinking about whether and how the fairness problem should be solved. So when I get these two tools on the table, and then maybe you can help me do the solving. My plan is to first kind of very briefly go over the need for allocation strategies. Why are we talking about this at all? I'll then kind of sketch the dominant model for allocating scarce healthcare resources. And then I will explain what I'm calling the fairness problem with the dominant model. And that's the goal of the first part, to show you that there's a problem. Then to kind of take some steps towards solving the problem to put these tools on the table. I'm going to talk very generically about what I take fairness, the demands of fairness to be. And then I'm going to explore some measures of fairness that have been recently developed by computer scientists and philosophers working on the fairness of predictive algorithms. And because I think we can view what goes on in healthcare triage as very much analogous to, in all the relevant respects, the predictive algorithms that these fairness measures are supposed to measure. So my hope is it can help us evaluate the fairness of our allocation strategies. And then at the very end, I'll say a few words about where to go from here. My hope is to leave about 15 minutes at the end for Q&A, hopefully more, but I'll shoot to wrap up about 7:45. So why are we talking about this? The last year has been instructive. In a crisis, healthcare resources are often scarce, and the scarcity can come in many flavors. We can have scarcity of diagnostic interventions. You'll recall early in the pandemic, there was a dearth of tests available. It was very difficult to get a coronavirus test. We can have scarcity of preventative interventions. Again, early in the pandemic, it was difficult to get a hold of masks, hard to buy hand sanitizer. More recently, the demand for vaccines has far outstripped supply. There can be scarcity of therapeutic interventions. Perhaps you recall remdesivir, which was given emergency use authorization by the FDA early in the summer. And again, supply fell far short of demand, and the government and hospitals were tasked with determining which patients would receive this drug. Can have shortages of equipment, ICU beds, ventilators. Can have shortages of healthcare workers to operate that equipment and to treat patients, and more. And when faced with scarcity in this way, we have to decide who will get these resources and who won't. And of course, these are very difficult questions to answer, but there's no way to avoid having to answer them. There's no kind of default option that we don't have any responsibility for. To give them out on a first come, first serve basis is to decide that those who come first will get the resource and those who come second won't. And insofar as we're responsible for distributing these resources, we as the kind of managers of a healthcare system, there's not enough of these resources to go around, we owe some justification for why we distribute them in the way that we do. So this is a question that given scarcity, we have to answer despite the difficulty of the question. It's also worth just very quickly emphasizing that these kinds of issues don't just come up in the context of a crisis. Even outside the context of a crisis, healthcare resources are sometimes scarce. We face scarcities in organs, hospital space, available specialists, money, and more. And so I'm not going to talk more about this, but I just kind of want to plant the seed. It's worth remembering that while the pandemic has made this question about how to allocate scarce medical resources especially salient, it's not a question that's unique to a crisis. And we should be taking care to apply the lessons that we've learned and are learning during this pandemic to improve the ways in which we deliver healthcare more generally. So of course, thinking about all these types of scarcity all at once would be enormously cumbersome and not make for a very good talk. So let's hone in on a specific issue of scarcity. So consider we're the head of a hospital. We have 12 ventilators. We can foresee a coming surge of COVID-19 patients, and we realize that we'll have more patients in need of a ventilator than we have ventilators. So we have to make a decision about how to allocate this scarce resource. And this is an especially important decision to make because it's to decide who does and doesn't get a ventilator is, not literally, but close to literally, to decide who lives and who dies. Right? It's a critical intervention for severe COVID patients. So how do we make such a decision? Over the last year, lots of hospitals across the country were faced with this very prospect that I just kind of sketched, and had to come up with a policy for how to allocate ventilators to severe COVID patients. And most of these policies fall under the umbrella of what I'll call, following Harold Schmidt and colleagues in a very recent paper from this year, called the dominant model of scarce healthcare resource allocation. The goal of the dominant model is to maximize the benefits of the scarce resource. And the justification for this goal typically appeals to something like our obligation to be good stewards of the scarce resource. So these resources are primed to do a lot of good for the people who need them and who stand to benefit the most from them. And the worry is that adopting any alternative goal would be, in a sense, to waste the scarce resource, to use this scarce and valuable resource in a way that doesn't do as much good as it could have done. It's a waste. There's also a kind of fairness justification for adopting this goal that's worth emphasizing, given that I'm ultimately going to be presenting a fairness problem with the dominant model. The fairness justification is that fairness demands that we treat like cases alike, and that differential treatment for two patients is justified only if there's a morally relevant difference between them. And it seems that whether one stands to benefit more than another from some scarce resource is clearly a morally relevant difference. And so it's very plausible to think that there's a sense in which fairness demands that we consider only these kind of like objective features of who's going to benefit the most from the receipt of these scarce healthcare resources, and we give out the scarce healthcare resources just on those grounds. Okay, to implement the dominant model, we have to do a few things. We have to identify the relevant benefit. So again, the dominant model, I maybe should have said this right at the start, we shouldn't think about this as just one model of one way of allocating scarce healthcare resources. We should think about this as a class of ways to distribute scarce healthcare resources. The goal is to maximize the benefits, but there are lots of different benefits you might choose from. So you might think the relevant benefit is quality adjusted life years, or near-term survival, or lives saved to discharge, or perhaps something else. Once you have a relevant benefit in mind, you need to construct a score to operationalize that benefit. So a significant majority of the proposed policies to allocate scarce healthcare resources use something like the sequential organ failure assessment, or the modified SOFA score. Sometimes this is used in conjunction with clinical diagnoses or clinical judgment, assessments of comorbidities, age, etc. So, but the goals of these scores are to produce some estimate of the relevant benefit that we're attempting to maximize for each patient. Finally, we need to prioritize allocation based on patients' scores. So once you have a score, then you need to use that score to determine who does and does not get the benefit. Okay. So again, given these choice points, the dominant model itself can come in lots of different flavors, as many flavors as there are combinations of deciding the relevant benefit, the relevant score, and how to prioritize based on that score. So again, we should think about the dominant model as not just one, but a class of models. Again, though, to make things more manageable, I'll primarily have in mind, I'll just make some simplifying assumptions, and I'll have in mind a version of the dominant model on which the relevant benefit is survival to discharge. This relevant score is a dichotomous score. It classifies a patient as one of two things. It will survive to discharge conditional on treatment, or will not survive to discharge conditional on treatment. And I'm going to assume that the score is quite accurate, but not perfectly so. Now, it's of course worth noting that actual triage systems are much more complicated than this. But despite these simplifying assumptions, similar considerations will apply to the more complicated versions. So that's why I make these assumptions. Excuse me. Okay. Okay, I want to canvas the available ways one might criticize some version of the dominant model to make clear what I'm doing and what I'm not doing in what follows. So one way in which you might criticize the dominant model is by or a version of the dominant model, is by accusing it of misidentifying the relevant benefit. So you might be on board with the general goal that, the appropriate goal of an allocation system for scarce healthcare resources is to maximize the relevant benefit, but you might think some version of the dominant model has misidentified the relevant benefit. So for example, the toy version we were playing with was that the relevant benefit was survival to discharge. You might worry that the survival to discharge discounts the value of the future of the young and healthy, insofar as survival to discharge will count the benefit gained by an 80-year-old patient who receives the ventilator and survives as the same as the benefit gained by a 25-year-old patient who is given the ventilator and survive. And you think that might problematically discount the value of the extra number of years that the young person has left in their life. I'm not sure that's a good criticism, but that's one way in which you might accuse the dominant model of misidentifying the relevant benefit. You also might accuse a version of the dominant model of mismeasuring the relevant benefit. So this is a frequent criticism of allocation schemes. It's that SOFA scores are not well calibrated. They're not the best measure available for near-term survival or something like this. Again, this is like the previous one, this is a good criticism. It's a criticism that's been leveled against versions of the dominant model, but it's not the criticism I'm going to be exploring today. In addition, you might be on board with some characterization of the relevant benefit. You might be on board with a measure of the relevant benefit, but disagree with how the score translates into prioritization for certain patients. So for example, you might complain that small differences in SOFA scores don't justify substantially different treatment between two patients. So here you'd be on board with the benefit and the measure, but worry about how the measure or the score manifests in prioritization. Okay, again, a good criticism, a criticism that's been leveled, not the criticism I'm going to be discussing. The type of criticism I'm concerned with is more foundational. You might worry that the dominant model has incorrectly characterized, or at least incompletely characterized, the relevant goal. So this is different from that first bullet. The first bullet is conceding that the relevant goal is maximizing the benefit and accusing some version of misidentifying the relevant benefit. This last bullet, the nature of the criticism is that maximizing the benefit, however you characterize it, isn't the right goal or isn't the only goal that we should have in mind. And that's what's going to be framing our discussion in what follows. To see what's problematic about myopically focusing on the benefits, suppose that we're using a SOFA score to determine our predictions. So if you have a SOFA score above 8, we predict that you wouldn't survive even with treatment. And if you have a SOFA score of 8 or below, we predict that you would survive if you were to give treatment. And on this basis, we give the patients with the high score low priority for ventilators and the patients with the low score high priority for ventilators. So this is a straightforward application of the dominant model. But note that we know some things about the kinds of patients that will fall into these two camps. We know that Black Americans exhibit significantly higher rates of comorbidities, such as diabetes, hypertension, heart disease, et cetera, than white Americans. And we know that comorbidities raise one's SOFA score and are associated with significantly higher mortality for COVID-19 patients. Given this, we can anticipate a significantly higher percentage of Black patients will comprise our low priority group than our high priority group. And so the dominant model in this case predictably has the effect of allocating resources away from a marginalized group and towards an advantaged group. This is a really key point, so I want to make sure it's clear. Given the systemic racism in our society now and in the past, Black Americans tend to have more comorbidities. They tend to be at baseline less healthy on average than their white counterparts. And given the ways in which comorbidities affect one's ability to survive to discharge or to gain some benefit from treatment in these circumstances, we can confidently predict that a score that is trying to measure the benefit that a person would receive were they to get treatment is going to give more priority to the people who are most likely to survive, who are going to be disproportionately white. This seems to me to be bad. And it's what I'm calling the dominant model's fairness problem. So just to summarize, since individuals from marginalized communities shoulder a significantly higher burden of disease than their more advantaged counterparts, on any plausible characterization of the relevant benefit, the dominant model will have the effect of allocating scarce resources away from members of marginalized groups and towards members of advantaged groups. So this was the goal, the first goal of the talk, to convince you that the dominant model has a fairness problem. Importantly, though, to say that there's a problem isn't necessarily to say that there's anything to be done about it. Whether the fairness problem is a problem to be solved, and if so, how to solve it, depends on exactly what's unfair about the dominant model. And so in the remainder of the talk, I want to, again, put some tools on the table for thinking through exactly what this seeming unfairness consists in. So to start, I want to think very generically about what fairness demands. Consider a pair of cases. Case one, Gertrude is a great student and Porter is a poor student. As it happens, they are the only two entries for their department's annual essay contest with a single prize of $100. Gertrude's submission is characteristically great, while Porter's is characteristically poor, and the department gives the prize to Porter. Priscilla is privileged, second case. Priscilla is privileged, Undina is underprivileged. As it happens, they are the only two applicants for a financial aid scholarship from their department. Because Priscilla is privileged, her financial need is moderate, and because Undina is underprivileged, her financial need is significant. And the department awards the scholarship to Priscilla. Okay, I have the intuition that these are two instances of unfairness. I hope you have that intuition too. If you don't have that intuition, perhaps that's a thing we could talk about in the Q&A. But so I have this intuition that these are two cases of unfairness. The unfairness calls out for explanation, and I think there's an explanation that's common to these two cases. And here it is. In each case, the distribution of the good that we are distributing, has failed to be responsive to some reason that we have to give the good to a particular person. And this, I think, reveals one of fairness's core demands. Fairness demands that we distribute goods on the basis of what I'm going to call merit or qualification. I want you to not read it too much into merit or qualification. I want these terms to be kind of catch-alls for any reason that makes it better or more deserving to give some good to one person rather than another. So we have, this is intended to just be saying the same thing with different words. We have a reason to distribute good on the basis of certain considerations, and whatever those considerations are going to fluctuate from case to case depending on the good and depending on the way in which it's being distributed. And I just mean merit or qualification to be catch-alls for those types of considerations. This sense of fairness, I think, is captured well, actually, by the dominant model of scarce healthcare resource allocation. So we have reasons to give scarce healthcare resources to individuals who stand to benefit the most from them. And this is the sense in which the dominant model, as I talked about, a handful of slides ago now, this is the sense in which I think the dominant model might be justified in part on grounds of fairness. So we have that somebody will benefit more from the receipt of some scarce healthcare resource is, in the sense that I'm using the words, a merit or qualification. It's a reason to give them that scarce resource. So I think the dominant model captures this sense of fairness, or is at least well positioned to capture this sense of fairness. But importantly, I don't think this kind of consideration exhausts the domains of fairness. Consider another pair of cases. Blair is black and Walter is white. As it happens, they had the two best entries for their department's annual essay contest. Each entry was equally good, but there is only a single $100 prize to distribute. The department chair is racist and awards the prize to Walter. Christian is Christian and Hina is Hindi. They both apply for a prestigious internship in the office of their state's United States Senator. They're equally qualified, but the senator is partial to Christians, so he selects Chris. Again, I think we have two intuitive instances of unfairness, but the unfairness in these two cases can't be explained in the way that the previous two cases were. It can't be explained in terms of a failure to respond to our reasons to distribute the relevant good, because by hypothesis, those reasons are balanced. The chair has just as much reason to give the prize to Blair as she does to Walter. The senator has just as much reason to give the internship to Christian as he does to Hina. So we can't explain the unfairness here in these cases in the same way that we did in the previous two, as a failure to respond to our reasons to give a good to a particular person. Instead, it seems to me that what explains the unfairness here is that there are considerations that fairness demands that we do not select on the basis of when distributing some good. Fairness demands that we avoid distributing goods on the basis of what I'll call, following the kind of philosophical literature and computer science literature that I'll talk about in just a second. Fairness demands that we avoid distributing goods on the basis of protected attributes. So in other words, we have a reason to not distribute good on the basis of certain considerations. Whereas the first demand was a reason to distribute goods on the basis of certain considerations. This is a reason to not distribute goods on the basis of certain considerations. And the dominant model is not well positioned to capture these types of fairness considerations. Oops. Okay. So summarizing just what happened on the previous two slides. When allocating some scarce but important good, we ought to distribute on the basis of merit or qualification, where again, merit and qualification are kind of catch-alls. And we ought to avoid distributing it on the basis of protected attributes, where a protected attribute is just some feature of a person that we have special reason not to discriminate against. So I think the unfairness problem for the dominant model of scarce healthcare resource allocation seems to be a problem of failing to avoid selecting on the basis of these protected attributes. That's the nature of the problem. And I think that's progress to understand that, like, if there's a problem there, that's the type of problem it is. It's a failure to avoid selecting on the basis of certain protected attributes. But you'll notice there's lots of fudge language in here. What does it mean, you might ask, to avoid distributing some good on the basis of a protected attribute? There's a lot of vagueness here, and because there's a lot of vagueness, there's a lot of ways to make it more precise. So before we can determine whether and how to solve the fairness problem, the dominant model's fairness problem, we need to get clear about what exactly the relevant sense of unfairness is, about what exactly the unfairness in the dominant model consists in. Luckily, there are lots of smart people working on exactly this problem, but in a different context. So big data and machine learning have facilitated the development of predictive scores that are used to estimate individuals' attributes or future behavior. These types of predictive scores are used all over the place. Just to give a couple examples, they're used in banking, they're used in advertising, they're used in criminal justice, and much, much more. But treatment on the basis of these scores, treatment on the basis of these scores has resulted in disparate negative impacts on people from marginalized communities. In other words, treatment on the basis of these scores fails to avoid selecting on the basis of protected attributes in exactly the sense that fairness demands that we avoid, I talked about on the previous slide. So this was a finding of a widely publicized, perhaps you saw it, a widely publicized ProPublica report on an algorithm that was used by some jurisdictions here in the United States to predict recidivism. And the report found that even though the algorithm did not use race as an input to determine recidivism score, it yielded a higher rate of false positives. So it was more likely to falsely predict that a Black person would, commit a future crime than it was to falsely predict a white person would commit a future crime. And so this was this worry that, like, look, that's a deep problem of unfairness with this system. And in response to that, philosophers and computer scientists, among others, have worked to develop fairness measures in an attempt to determine when the treatment on the basis of some score is fair and not fair. So in response to these predictive algorithms and the fairness problems that they raised, computer scientists and philosophers are attempting to kind of measure the fairness of these predictive algorithms. And in what sense? Well, in the sense that they measure whether and to what extent a score does that thing that fairness demands, avoid selecting on the basis of a protected attribute. Now, it's important to note, and this is the kind of pretense of the project. It's important to note that there's a strong sense in which the dominant model of scarce healthcare resource allocation just is making a prediction about patients, about whether they would survive with treatment or would die with treatment, and then allocating some important good on the basis of that prediction. So it's doing the very same thing that these philosophers of big data and computer scientists are looking to evaluate. And so here's the thought: maybe we can use their tools, use the measures that they've come up with to assess whether and to what extent the versions of the dominant model are fair or unfair. So that's what the rest of the talk is going to be today. I'm going to go through some of those measures that have been proposed and invite you to think about whether and to what extent they do or do not capture the kind of unfairness that we're concerned is exhibited in the dominant model of scarce healthcare resource allocation. So first up, first measure we'll consider is fairness through unawareness. And there's a strong sense in which this is the most straightforward one. This is papers and surveys on this topic very often start with this one because it's the easiest to grasp, and it's also not a very good one. So fairness through unawareness classifies a predictive score as fair in the relevant sense if and only if it does not take any protected attribute as an input. So according to this measure, is the dominant model fair? Or might a version of the dominant model be fair? And the answer is clearly yes. So long as race, religion, sex, gender, etc., whatever you consider to be the correct list of protected attributes, are not themselves among the inputs that determine a patient's score, fairness through unawareness will be satisfied. But it's precisely for this reason that the sense of unfairness is so easy to achieve, and it's widely thought to be an inappropriate measure of fairness in at least most cases, if not all cases. This doesn't capture all of what we care about when we care about fairness, when we care about avoiding selecting on the basis of protected attributes. And for our purpose, it's clearly not up to the task of explaining the unfairness in the dominant model, because according to this, there just is no unfairness in the dominant model. So if we want a fairness measure to help us here, we're going to have to look elsewhere. So let's consider demographic parity. So demographic parity maintains that a score, predictive score, is fair in the relevant sense. Again, the relevant sense is it avoids selecting on the basis of a protected attribute, if and only if the probability that an individual receives a score is independent of any protected attributes. What does that mean? That means that the protected attributes are not correlated with the score. What does that mean? Well, here it is in symbols, if you like symbols. And the probability that that somebody is predicted to be. I can see Robert. Robert, can you see my mouse? Yes. Great. Okay. So the probability P sub S, the probability that somebody is predicted to be to survive conditional on treatment, given that they have some protected attribute. I'll just again, because it's salient in this context, use is black. So the probability that somebody is predicted to survive conditional on treatment, given that they're black, is equal to the probability that a patient would be predicted to survive conditional on treatment, given that they're not black or that they're white. So the thought is we should see, to satisfy demographic parity, we should see parity among the rates of our predictions in each group as defined by their protected category. According to this model, measure is the dominant model fair? The answer is clearly no. Given what I said at the beginning, I mean, this is the kind of clearest way in which the dominant model fails to be fair according to one of these measures. Given a marginalized community's burdens of disease, as I mentioned before, this is inconsistent with the dominant model's goal of maximizing the benefit. In order to get equal rates of prediction for people, for blacks and whites, we would have to become wildly inaccurate for at least one of the groups. And becoming wildly inaccurate is going to frustrate your ability to maximize the benefit of your scarce resource. Being wildly inaccurate in your predictions about who would survive with treatment and who wouldn't survive with treatment. So the dominant model fails to be fair according to this score. And so this score plausibly does capture a sense in which the dominant model is unfair. But there's still other fairness measures available that warrant consideration. So we shouldn't stop here. This one's at least primed to capture the sense in which the dominant model is unfair, but perhaps another score could do better. So consider classification parity. According to classification parity, a score is fair in the relevant sense if and only if the classification error is equal across groups defined by their protected attributes. So this is, again, famously the kind of fairness, if it is a kind of fairness, that the recidivism algorithm examined by ProPublica failed to capture. And this, again, classification parity demands that we have equal rates of false positives and false negatives for different groups, again, as defined by protective attributes. What does it mean to have a false positive? Well, the probability that we predict that you would die conditional on the fact that you would survive. So the probability that we have a false prediction given that you're black is equal to the probability that we have a false prediction given that you're white. According to this measure, is the dominant model fair? Answer is maybe. But almost certainly not. So it could be that our most accurate prediction that we're using to try to maximize the relevant benefit satisfies classification parity. But that's going to happen only if we have identical base rates of the feature of interest, in our case survival or not, among the groups as defined by their protective attributes. So if you have different base rates, then you're going to have different error rates, and you're not going to satisfy classification parity. I meant to say something that I forgot. So why should we care about classification parity? Well, think about what it means to get a false positive, to be falsely predicted to die conditional on treatment, even though you would survive. Well, that means you're going to be assigned low priority and you're not going to get the ventilator and you might well die. When in fact, if we knew more about you, right, if we were being more accurate, we would notice that you were likely to survive, and then we might give you the ventilator. So the fact that there are higher rates of false positives for Black people than for white patients means that we are mistakenly giving Black patients low priority more often than we are white patients. And so that's why this is the type of thing that the folks who work on this think we should be worried about. Again, that's a plausible measure that measure very plausibly captures the sense in which the dominant model is unfair, but note, there's still more measures out there. One more that I'd like to consider. This measure is called calibration. And calibration maintains that a score is fair in the relevant sense if and only if the outcomes are probabilistically independent of the protected attributes given a score. I'm going to try to go a little bit quicker because I realize I'm taking longer than I anticipated. Okay, so according to calibration, if we predict survival or not, then the probability that a patient actually survives should be the same no matter her protected attribute. I won't go through the symbols here. Here's another way to say it in, I hope, graspable English. A prediction of survival or non-survival should mean the same thing whether you're black or white. That's what calibration demands. So the probability that you'll actually survive, given that I predict you'll survive, should be the same regardless of whether you're black or white. Seems like a plausible demand of fairness. According to this measure, is the dominant model fair? This one's a genuine possibly, but possibly not. So here's the way in which satisfying calibration might conflict with. Here's an example of a way in which satisfying calibration might conflict with our goal of maximizing the benefit. If features of white patients allow us to make more accurate predictions about their chance of survival than black patients, then calibration is going to be inconsistent with maximizing the benefit because calibration is going to be inconsistent with using our most accurate predictions. But so long as that's not true, if we're kind of equally, if we have a measure that's kind of equally good in this sense for white patients and black patients, then we might well satisfy calibration while still pursuing our goal of maximizing the relative benefit. Okay. So now at this point, you might say, Ben, why are you trying to make me choose among these various measures? Sure, we see that fairness conflicts with this the dominant model's goal, maximizing a benefit. But why choose just one fairness measure? Why not come up with a score that satisfies them all? Of course, once we come up with such a score, we're going to have to think about the trade-offs in our ability to maximize benefits and our scarce resource. But before we tackle that problem, let's just come up with the score that is perfectly fair and see what it looks like. So why choose among these? Let's just come up with a score that's perfectly fair and then evaluate from there. The reason we have to choose is that it turns out that these plausible measures of fairness are not mutually satisfiable for all but a trivial range of cases. So the trivial range of cases is something like there exists equal base rates among all the groups as defined by their protected attributes. So by trivial range of cases, I mean a range of cases that we can expect to literally never see in the real world. So you can't satisfy all three of these. And they have mathematical proofs of this, and I'm not going to show it to you, but I totally could if you asked me. I couldn't really, but I will illustrate it with a case. I trust the mathematicians that they've shown this adequately, and I'll just show it with a case. So this is pulled directly from a paper by Clinton Castro, who's a philosopher at Florida International University, and he uses this chart here to illustrate the fairness problems with that recidivism measure that we talked about before. And so what I've done is I've just borrowed his very nice representation of the numbers and substituted in facts about predictions of survival versus not, and patient demographic information, whether they're black or white. So this is so suppose we have some score that results in these predictions where we have 300 black patients. We predict 100 of them will survive or would survive with treatment, and 80 of them would actually survive with treatment. We predict that 200 of them would die with treatment, and it turns out that's true of, so the red is the would die characterization. That's true of 160 of them, and you can see how it works with the white patients as well. So a score that results in this distribution satisfies calibration. The probability that somebody survives, given that, the probability a patient survives, given that we predict survival and that patient is Black, is 80 over 100. That's 0.8. The probability that somebody survives, a patient survives, given that we predict that they'll survive and they're white, is 80 over 100. So those are equal. Similarly, the probabilities that we predict that a patient would die, given that we predict that they would die and they are Black, that's this column here, is 160 over 200, 0.8. And the probability that a patient would die conditional on them being white and us predicting that they would die is, again, 0.8, 40 over 50. So satisfies calibration. Great, that's nice. But it's very clear that it violates demographic parity. The probability of being predicted to survive, given that you're Black, is we have 300 Black patients. We predict 100 of them will survive. So the probability that we predict that you'll survive, given that you're Black, is 100 over 300, which is 0.33. The probability that we predict that you will survive, given that you're white, we have 150 white patients. We predict 100 will survive, is 100 over 150, which is 0.67. So the rate at which we are predicting white patients will survive is far higher than the rate at which we are predicting Black patients will survive. So we don't get demographic parity. And if demographic parity strikes you as a plausible way to measure fairness, then this is deeply worrisome, despite the fact that this score satisfies calibration. Similarly, this score violates classification parity. In the interest of time, I won't go through these details. Like I trust the mathematicians, maybe you can trust me. The false positive rate for Black patients here is much higher than, at 33%, much higher than the false positive rate for white patients. And again, a higher false positive rate seems really bad because we're falsely predicting that you would die and thereby depriving you of an important resource on those grounds. So we can't have it all. We have to choose which measure we care about or which measure we care most about. And only then we'll be able to say what's exactly unfair about the dominant model. Or perhaps we need to come up with some other measure that I haven't discussed here. And I should note that there are other measures on offer that, for interest of time and capacity, I didn't go over. So where do we go from here? I'll wrap up very quickly. The dominant model of scarce healthcare resource allocation has a fairness problem. Given the background health disparities and the racism in our society, maximizing a scarce resource's benefit requires us to disproportionately allocate it to members of advantaged groups, in particular white people over Black people in the kinds of cases I've been discussing today. It's worth noting, though, that it's not a foregone conclusion that this is a problem to be solved. Again, I don't want to appear insensitive to the fact that these are resources that are saving people's lives. And if we abandon the goal of maximizing the benefits of this scarce resource, what that means is that more people die. So I think this fairness problem is a problem. I think possibly we should address it, but I'm not insensitive to the trade-off that addressing it might cause more people to die, and that's really bad. Okay, so if this is a problem to be solved, it's not clear how to solve it. As the various fairness measures demonstrate, there are multiple ways to interpret the unfairness of the dominant model, and they're not mutually solvable. So to determine whether the fairness problem should be solved, and if so, how we should solve it, we have to say exactly what sense of fairness or unfairness we care about. Again, I think it's plausible that it's worth sacrificing some benefit for the sake of fairness, but we can't take the step until we get more clear about what the unfairness in the relevant sense is. And my hope is that the tools I've put on the table can help us with this, but I confess that there remains much work to be done. Here are some references I used, and that's it. Thanks for your time. Sorry, I went a little longer than I anticipated.
Thank you very much. It was a lovely and enlightening talk. And as before, we do encourage questions. Feel free to flood the Q&A. But first, I was going to ask some of my own. So one question I had was just, we have these different measures. They have different properties that include, sometimes making more false predictions for one group than another, different kinds of false predictions they can make. Sometimes those predictions are really unfortunate because they mean that even though you would have survived if you got the ventilator, you don't get the ventilator, and so then you actually die. A huge bummer. I could see why I would be super concerned about the operation of a scoring rule like that if I thought it might do that to me. And so, at least for that kind of fairness, it seems like it has a really direct connection to what you might call, in jargon, the prudential interests of patients. But basically, patients of different races coming through the system would have a reason to really care about that measure. Just like trying to think through, starting from that perspective, is there a reason for me as a prospective patient to be more concerned about whether the system satisfies one definition of fairness rather than another? I'm sorry, is that a clear enough question to work with, Ben?
So let me just repeat it back to you in different words to make sure I understand. So the thought is like, look, I've got a pretty good grip on why it's bad for such a system to violate classification parity. Given that I've got such a good grip on that, why look elsewhere for instances of unfairness?
So, I mean, that's a fine question to answer. It wasn't exactly the question I intended, but that's also fine.
Okay, let me say just a couple things about the question you didn't ask, and then I want you to.
Yeah.
I'm sorry that I didn't grasp it all the way. So I do. It's not. This is one of the things that I think is really hard about this. It's not super obvious to me exactly what the fairness measures are supposed to capture. So I've characterized them, and this might be a mistake, I don't know. I've characterized them as attempting to capture whether a prediction is unfair, or the treatment on the basis of a prediction is unfair, in virtue of failing to avoid selecting on the basis of protected attributes. Seems to me that, so, and in fact, a paper by Brian Hedden suggests this to me, that folks who might endorse calibration might think of calibration being justified on the grounds that it captures both our reasons to avoid selecting on the basis of protected attributes and our reasons to select on the basis of whatever the relevant merit or qualification is. And because it captures the ways in which we want to be, equally, we want the prediction to mean the same thing for people from different groups. So I think part of whether a particular measure is going to appeal to you is going to depend on what you might independently care about, what you grasp onto. I think the demographic parity is super plausible when you come at this just from a general kind of social justice perspective and say, like, look, the reason that Black people suffer higher rates of comorbidities is because, like, there's been they've been independently wronged. And so it's really terrible to kind of pile on top of that and give them a lower probability of having a high priority score than their white counterparts who have been privileged in this sense.
I guess one thing I'm curious about with demographic parity, though, it's interesting to bring it back to that as a particular justice measure. I mean, is it possible to ever satisfy demographic parity without just allocating by race? Like, doesn't demographic parity crowd out any information that isn't race, because literally any other factor of interest is going to be unequally distributed between races?
Yeah, I mean, you might be able to consider other factors, but then have to correct for those factors to get them. So you're absolutely right. You'd have to explicitly consider race, practically.
So not just explicitly, exhaustively. Like, even if your SOFA score, we just like subtracted one if you were Black, wouldn't we still not have demographic parity at the end?
Yeah, I mean, I also think more about exactly how, so I'm inclined to think there are lots of ways in which we could satisfy demographic parity. And so then we could choose between the ways in which we satisfy demographic parity by choosing more or less accurate of those ways that satisfy measures. And so to get that accuracy, we're going to have to appeal to other facts about patients. But I don't think it would just consider race. But here, let me say one more thing. I don't think it's super plausible that, just to see how the relevant considerations interact with each other here, I don't think it's super plausible that we should, all things considered, endorse an allocation strategy that satisfies demographic parity. But you still might think that demographic parity is the right measure of fairness.
And so fairness is one of the things that matters. And exactly. So then, okay, that's correctly describing the sub-region of choosing a role which fairness occupies. Yeah, okay.
So we have reasons to select measures that like more closely approximate it than others, but all things considered, maybe we should select something that is unfair, not perfectly fair, but more fair than the dominant model.
So I've asked you a couple of questions and taken up some of our time. We only have a few minutes left, so I'm gonna drop you with just a little question from the chat, just a small question from the Q&A that you can have a minute and a half or so to answer before I'm gonna cut you off. So we're trying to operationalize fairness, but we haven't analyzed the notion of fairness in the first place. What is it to be fair? What is the notion of fairness at issue? Asks one of our commentators from the chat.
That sounds like something one could write a dissertation on. So I'll say, like, I hope, and this is the hope of the project, that I can be largely non-committal about the particular reasons that we have to reasons generated by fairness to give somebody a good and reasons to avoid giving particular individuals good on the basis of certain attributes. So I want to be non-committal about what counts as a merit or qualification and what counts as a protected attribute. And I think part of the project of determining what fairness is answering those questions. But I think we can see the way in which the dominant model is unfair without answering those questions. Why? Well, because the dominant model seems to be only sensitive to that first type of fairness consideration, that first type of fairness demand. And it's just kind of completely, it doesn't even attempt to satisfy that second type of fairness demand where fairness demands that we avoid selecting on the basis of certain protected attributes. So of course, there's lots and lots of work to do to fill in the details about what fairness demands. And I think it's super plausible to think that what fairness demands and the types of things that are kind of fairness reasons are going to vary from case to case. But I think I can execute this project while remaining neutral on that by just highlighting a certain type of fairness consideration that the dominant model can't accommodate.
What a nuanced and reasonable answer. Very, very nice. We're a minute from time right now. We're gonna shut off the event right at 8. I want to thank everyone in the audience for joining us. I want to thank Ben for coming and taking some time to talk about his research. You will, if you're here, it means you signed up, and you will get a link to this recording later, so you can review it if you'd like. And I also want to note that this is the third and second to last of the events in this series. So if you came, you had a good time, consider coming again next month. Last Thursday of the month, 7 p.m. Dana Howard will be coming from Ohio State University to talk about putting parents on a pedestal, the ethics of responding appropriately to parents of children with disabilities when they describe the experience of parenting those children. It's going to be good stuff. Thank you all very much for joining us, and I am going to sign off now.
Thanks, Robert.